James Winston Phillips, MD. This is chapter 5, the integumentary system. Function of the integumentary system is protection from abrasion, from bumping and invasion. Thermal regulation also involves the regulation of water and some salts, communication of the external environment, nerve receptors, metabolic function, turning modified cholesterol into a vitamin D precursor. The skin and its appendages cover 1.2 to 2.2 square meters, can be divided into 3 layers: the epidermis, the dermis, and the hypodermis. The epidermis, the dermis, and the hypodermis. The epidermis, the dermis, and the hypodermis. This is the epidermis that consists of 4 to 5 layers and 4 cell types. This is the dermis, which consists of a papillary layer and the reticular layer, and this is the hypodermis. The epidermis consists of layers going from deep to superficial: the stratum basale, the stratum spinosum, the stratum granulosum, a layer in here which we don't see, but you see in thicker skin, the stratum lucidum, and the stratum corneum. Typically, the epidermis and dermis make up the skin or dermis or cutaneous layer. The hypodermis is a subcutaneous layer, but it's talked about when we talk about the skin appendages. So we just put that in as a layer. Epidermis structure and location: it consists of keratinized stratified squamous epithelium. Remember, we also have stratified squamous epithelium in the oral pharynx, but it's not keratinized. We don't need keratinized in the oral pharynx. We do need stratified, because if we eat a potato chip with some rough edges and swallow it, we could take off several skin layers, okay? But we don't need to have keratin, because we have additional protection in the oral pharynx and through the GI and respiratory system, as opposed to the skin. The keratin is one of the mechanisms for protection. They are 4 cell types and 4 to 5 cell layers. The first cell type is the keratinocyte, which produces keratin. It's the most common cell type. It arises in the deepest layer, which is the basal layer. That's why it's called stratum basale. It's attached to the dermis. This is the dermis right underneath it. This would be the papillary dermis. This is one of the papillary ridges pushing up into the epidermis, okay? Continuously divides by mitosis and pushes itself upward to the apical surface. Protection: whole new layer every 25 to 45 days, so that's why we need continuous production and continuous mitosis. The next cell type is melanocytes, which produce melanin. They're found in the deepest layer of the epidermis. They attach the pigment, the melanin pigment, into the apical surface of the keratinocytes. So in the deep layers, we have the keratinocytes and the melanocytes. Keratinocytes are the cells that are going to produce keratin, that are going to provide the outer protective covering in the epidermis, and the melanocytes are going to attach pigment, melanin, to the apical surface, so the surface which is going to be pointed outwards of the keratinocytes for UV production. UV protection. Functions protect cells from UV rays. Next cell type is tactile or Merkel cells, found at the epidermal-dermal border. They are sensory receptors. We do not have nerve sensation in the epidermis itself, but we do have this nerve sensation, our first sensory receptors at the junction epidermis-dermal border. And then finally, we have a dendritic cell, or an Isle of Langerhans cell, which is a macrophage. Okay, epidermal dendritic cells is the correct name nowadays. In the old days, we had people's names attached to them, but nowadays we don't. This is macrophages. These are the scavenger cells. They are looking for foreign material and invaders if there is a breakdown of the barrier, okay? These are our layers from deepest layer: stratum basale, stratum spinosum, stratum granulosum, stratum lucidum, which you rarely see. It has to be very thick skin, and stratum corneum. But these are our 5 layers, and we went over our 4 types of cells. The deepest layer is the stratum basale, single layer of cells that's attached to the dermis like corrugated cardboard. So if you've ever look at cardboard and peel off that most superficial layer, you see a whole bunch of ridges. That's the corrugation, okay? They are the youngest keratinocytes, and they are the layer of rapid division. The next layer up is the stratum spinosum. There they have filaments, or the desmosomes, which is one type of cell junction that we talked about. They are for keeping cells together and not being sheared off, okay? Not being sheared off because the skin moves in multiple directions, has multiple forces applied to them. Cell types there are the keratinocytes, and this is where we have our macrophages, or our dendritic cells, or our cells of Langerhans. These are our scavenger cells. Next layer up is the stratum granulosum, 2 to 5 layers thick. This is where the keratinocytes start to die off due to the increased production of keratin. There's only so much room in the cell, and as the keratin increases, there's less and less room for the organelles, so the cells starting to die off in this particular layer. The stratum lucidum, which we don't see here, is a clear layer. It is only seen in very thick skin, okay? That'd be the skin of the buttocks, the skin of the back, skins of the soles of the feet. And it's named here, and you need to learn it as one of the named layers, but you rarely see it on the slide. And then finally, the stratum corneum, which is the outermost layers, 20 to 30 cell layers thick, contains keratinized cells and glycoproteins that serve to protect and waterproof the skin. So once again, stratum basale, stratum spinosum, stratum granulosum. If we had it, it would be in here, the stratum lucidum, and then finally the stratum corneum, okay? Next, we're going to talk about the dermis, okay? We have two sections, remember this is epidermis, we have two sections of the dermis, the papillary and the reticular layer, papillary layer and the reticular layer. Remember, we have three sections here, epidermis, dermis, and hypodermis. We're now down to the dermis. Dermis is a composition of flexible connective tissue. They are all these cell types. These cell types are what we talked about when we first started talking about connective tissue. We have fibroblasts, macrophages, mast cells, leukocytes, collagen, elastin, and reticular fibers, nerve fibers, blood vessels, and lymphatic vessels. There is no direct blood supply in the epidermis. The epidermis lives by diffusion and active transport. The mechanisms we talked about, transport, both passive and active. That's how the epidermis lives. And so the blood vessels, nerve fibers, and other types of things, we learned that our Merkel's fibers, our nerve fibers, were at the junction of the epidermis, dermis, blood vessels, lymphatic vessels here. So this is just our picture of areolar connective tissue when we first started looking at it. Papillary lesion consists of areolar connective tissue located just below the epidermis and contains these nerve ends and these structures we talked about. Also, we had those dermal projections, that corrugated cardboard effect that we talked about. Those are responsible for fingerprints. Those are the ridges on your fingers. This is a scanning electron micrograph at 12 times, which shows what fingerprints look like scanned in under 12 magnification. In the reticular region, we have dense irregular connective tissue. When we talked about connective tissue, we had dense regular connective tissue, which were parallel fibers in a row. These were in ligaments and tendons where the tension is in one direction. We had dense irregular connective tissue where the fibers were in a haphazard arrangement because the forces of tension were in all directions. So the reticular region, the papillary regions are made of areolar tissue primarily. The reticular region is primarily made of dense irregular connective tissue, 80% of the dermis. Collagen fibers create tension lines, okay, because we'll have tension lines in all directions. We also have flexure lines, tight underlying attachments to underlying structures. So these are palmar creases here, flexion lines in the palm. These are our attachments to the dermis, to the dense irregular connective tissue, and then usually to an underlying connective tissue, usually to a bone, and or some deep type structure, and that will give us these flexure creases in the hand. Cleavage lines, if you look at these cleavage lines, what these represent are areas that if you're doing a elective excision or an elective repair or something, you would like to put it in these cleavage lines because this is how the body's tension lines are set up. So this would obviously give you the best scar. If it's trauma, there's nothing you can do. Trauma is trauma. But if you're doing elective things, say you're doing an elective, if you're removing a mole, you're removing a skin cancer, you would like to do it in the direction of these cleavage lines to give you the best potential for a scar, all other things being equal. And so this is what this is, okay? Next is the hypodermis. Subcutaneous tissue contains adipose cells, areola connective tissue, anchors skin to the underlying structures. Usually it's muscle, but it could be tendons, could be bone. Stores fat. This is where the fat's stored if we consume more calories than we use, and protects from heat and mechanical jarring. Accessories and appendages. We're going to discuss a number of glands. Obviously, you'll have the notes with you. These are our sweat glands. We have a bunch of them, 3 million of them. They secrete a lot of different things: water, salts, vitamin C, antibodies, metabolic waste, and lactic acid. The fatty acids and proteins from some of the glands are decomposed by bacteria and give off an unpleasant odor, as we all are aware, okay? These are sebaceous glands that are usually attached to hair, okay? They are secreted to lubricate the hair and have an antibiotic in them. These are other type of glands. Merocrine or eccrine glands. These are glands on the soles of your feet, your hands, and your forehead. Deal with thermoregulation. They're also, some of them are connected up to the sympathetic system, as you're well aware. If you get into a situation where you're nervous in an interview or something like that, your palms may start sweating, your forehead may start sweating. It's related to these merocrine or eccrine glands. We have apocrine glands, which are deeper glands, which we talked about, that larger and deeper, that have the fatty acids and proteins that when they decompose gives us a smell. We have ceruminous glands, which are responsible for earwax, and mammary glands, which are in the breast, which under hormonal stimulation from pregnancy become modified for milk production. Okay, and finally we have sebaceous or oil glands. Everybody has those. Lipids and cell fragments, they lubricate the hair and skin, slow water loss, antibacterial. Hair composed of dead keratinized cells. Hair composed of dead keratinized cells. Hair is composed of dead keratinized cells. We spend a lot of money on dead keratinized cells. Extends through the epidermis into the dermis and maybe into the hypodermis. That's the follicle. Okay. The matrix down here, we have a germinal center from which the hair is produced. Germinal center from which the hair is produced. It produces the hair cells, and then the hair cells are pushed forward for the hair growth. We have the root, which is embedded in the skin, the shaft, which is the hair above the skin. This is, other than knowing about the germinal matrix, the other thing about the hair, which I'd like you to know, is this muscle right here called the erector pili. When we have certain stimulations, when we get frightened, and then sometimes if we hear a song or hear a powerful speech or something like that, our hair shafts stand straight up. Our hair stands on end. That is because of contraction of this muscle, the erector pili. Guaranteed you'll see that on the test in some form, matching, multiple choice, true, false, something like that. The nails, biggest thing about the nails right here is a germinal matrix for the nail. Right here is the germinal matrix for the nail. The fingernail is, there again, dead keratin, okay? Cells are produced right here and pushed forward on the nail. If you have a crush injury of the distal phalanx, okay, we have a proximal, middle, and distal phalanx. This is the last part of the finger from the crease outwards, okay? If you have a crush injury, which would be in this area here, then you may kill the nail matrix may be non-viable. And if it's non-viable, that means the nail's not going to grow, okay? And since we are very hand-oriented, that could be a devastating injury, okay? Could be a devastating injury. Back in the day, some 30 years ago, we were transplanting nail matrices from the toe, putting them up here. We take a sliver from the toe, usually from the great toe, and put it up here to see if we could get it to grow, okay? I don't know what the current treatment of choice is, but like I say, you want to make sure that if you see a patient with a crush injury of the distal phalanx, especially in this area here, that you be concerned about the nail matrix. Also, you need to have good alignment of the distal phalanx, because this nail is going to grow forward on this platform. It's going to go forward on this platform. And so if you have an obvious deformity here, which you could very well, if you had a fracture of this distal phalanx here and it healed with this distal portion going anterior, remember the anatomical position includes the palms facing outwards. So if this went anterior, then the nail will go along whatever surface you have. So if you cannot get it aligned through just manipulation, you might have to take the patient to the to the OR and put a pin down here to get good alignment so the nail will grow back straight. Nail matrix is the primary thing that I'm concerned with crush injuries and alignment of the distal phalanx, the parts you know. Nerve receptors, they are responsible. Remember, everything that comes from outside, we receive through some kind of receptors, whether it be we see it, we hear it, we taste it, we smell it, we perceive it through touch, pressure, chemicals, hot, cold, okay? We also have thermal regulators. In the arterial, capillary, venous system, we have circular smooth muscle around blood vessels, okay? If our internal body temperature reaches a point where we need to get rid of some heat, okay, we would like to get rid of that heat. The easiest way to get rid of the heat is to the smooth muscles in the venous system, which is close to the periphery. Everybody can see that. That's the veins on your arm and your hand, the backside of your arm and your hand. If the smooth muscle relaxes, they dilate up, okay? And so that will bring that warmer blood, okay? And so you can exchange heat with the outside environment if you dilate at the smooth muscle. So that's a way of doing thermal regulation. The problem becomes if the external environment temperature is equal to or greater than your inner body temperature. If that happens, then no heat exchange is going to occur. And so that's why you hear about older people or people in the Midwest dying from heat stroke and heat exhaustion, because even though they got the windows open and fans going, the external temperature is either equal to or greater than their body temperature, so they're not able to exchange heat. Always remember that the very old and the very young don't tolerate big changes. The very old and the very young you have to protect. To retain heat, we just do the opposite of that. We contract those smooth muscles, circular smooth muscles in those external veins that are ones that are closest to the outer surface, and that diverts that warm blood back internally, okay, to keep it near the internal organs. The brain can also stimulate sweating, as we well know, if we get nervous, and as sweat evaporates, it takes heat with it. Or disorders of the integumentary system, skin cancer, you're going to need to know these. You need to know these, number one, for your next exam, but number two, because if you're going to be a healthcare professional in Florida, you need to know about these, because you're going to take care of patients that have basal cell squamous cell and maybe melanoma, certainly these first two. You may not see somebody with melanoma, but most of you, especially if you go outside boating, like to go out and lay in the sun, swimming like me, you play golf, you're going to get basal cell carcinomas. It's just a fact of life in Florida. These originate from the stratum basale, invade the dermis. They look like this. They're raised, they're usually round, and they're pearly. They almost 100% look like this. And if you see it's a basal cell carcinoma, if you have the capability and the privileges to take it off, you just put in a little local anesthesia around here, take about a 1 millimeter, maybe 2 millimeter margin around it, take it in an ellipse in your lines of cleavage to get the best scar, take it out, put a couple stitches in, send the specimen to pathology, bring the patient back in a week, okay, bring the patient back in a week and go over the pathology, make sure the margins were clear, take the stitches out and you're done. Always remember that in the state of Florida, there is a law that if you have insurance, you do not require a authorization from your primary care doctor to go see a dermatologist. You can just pick up the phone, call the dermatologist, tell them what insurance you have. If they take your insurance, you can make an appointment. You don't need an authorization to see a dermatologist. You can see the dermatologist one time a year for examination of your skin to check any type of skin lesions, or just check, skin exam. And then obviously you can see them more if you have a skin cancer. But this is a basal cell arises from stratum basale. Very common, very common. You can make a practice just taking these off. Next is the squamous cell carcinoma. It's usually red, it's scaly looking, usually larger, irregular borders, rises from stratum spinosum, can metastasize unless caught early, grows fast. If you were to see this and you had the capability, you would want to take a punch biopsy. So if you had a punch, so it's a little round tool, you put a local in, you punch it down, take a little piece of skin out. You can usually put a steri strip or put one stitch in, bring them back in a week, find out their pathology. And if it's a basal cell and if it's a squamous cell and it's that big, okay, unless you have the capabilities of taking that off and getting adequate margins. See, margins are easy here, okay, because you have a well-defined lesion. Here, it's not so well-defined. Is this part of the lesion here coming down here? Obviously, if you're in person, it's easier to see, but it's still harder to get margins here. And so you might need to send them to you might need to send a plastic surgeon, to a dermatologist, to a general surgeon, whoever does these types of things in your community. You're not capable of doing it. But you can get a biopsy of this with a punch biopsy and bring them back and get a diagnosis and then send them out for definitive care. This is a melanoma. This looks more like Kaposi sarcoma and HIV, okay? But melanoma can look like anything. They're different colors, they're different shapes, okay? They arise from the melanocytes, the most deadly of the three, require surgery, radiation, maybe chemotherapy. If you have a patient with a melanoma, that's an urgent consultation to send them to somebody who takes care of melanomas and knows what the standard of care for treatment in 2020 is for melanomas. Hidden by pigment, highly metastatic. If lesions over 4 millimeters thick, chance for survival is poor. That's why it's an immediate consultation. You pick up the phone and call. If you're not somebody that takes care of these, if you don't work in the dermatology office, plastic surgery office, general surgery office, you pick up the phone and call the office, the dermatologist who we're going to send to them, get your patient an appointment that week to be seen. If you're not of that level, so if you see any of those three lesions, okay, and say you're a physical therapist or whatever, and they ask you about it, then you say, well, I don't know what that is, but I remember that if there's any suspicion at all, you ought to go see your doctor about it. And if you want to, you can see a dermatologist if you're in the state of Florida, okay? And even if you know if it's a basal cell and it's not your responsibility to diagnose, because you don't want to diagnose anything if that's not in your realm of what your clinical responsibilities are. An example would be a physical therapist. If that's not in your realm of diagnosis, you want to make sure that they get to see their primary care doctor, and you might put a note in the chart asking them next time, or put a little sticky note on the inside of their chart as opposed to a note in their chart, asking them if they went to see somebody next time you saw them. Next big category of pathological conditions is burns. We have three types of burns. They're the leading cause of accidental death due to fluid loss, infection, toxic effects of eschar. They can be superficial and very small. They can be very deep, full thickness, third-degree burns, and over extensive surface of the body. First-degree burns, superficial burns, only the epidermis. As long as there's not infected, you can treat them with polysporin, triple antibiotic ointment, and they will heal up without a scar. Second-degree burns are epidermis and the dermis. If they're small, very small area and not in critical areas, not on the face, not on the hands, not on the feet, not in the genitalia, then they're very small. Small being, an inch or two by an inch or two. You can treat them locally, triple antibiotic ointment, keeping them clean with the dressing, seeing them back fairly frequently, and as long as they don't get infected, they may heal, but with a little bit of scar, okay? It's going to get a scar if you get a skin graft, so if you can avoid a skin graft, and these have the ability to regenerate tissue, okay? Regenerate skin, so if they're not very big, they will heal up, they may have a scar. but they got to be kept clean and not get an infection. Third-degree burns, if it's a very, very, very small area, it's a full thickness burn. It's all right. It's all the way through the epidermis, dermis, probably into the hypodermis, and could even be, if it's on top of a muscle, could even be into the muscle tissue, depending on how deep it is. An electrical burn, a lightning burn could go down and have a very small entrance hole, actually have a full thickness burn through the skin, radiating outwards to the skin, and actually have dead muscle below. So it's different varieties based on what the burn type is, but these people usually get admitted to the hospital if it's very big at all, because it's going to be a full thickness burn, and they're going to have problems with infection, problems with pain management, may or may not have problems with pain management. Usually do, not where the burn is itself, because the nerve endings have been burned, but the fact that it's not just a sharp demarcation. You'll have portions that are full thickness burn, and right next to it, you'll have portions that are partial thickness burn. The portions that are partial thickness burn will still have intact nerve receptors, and they will hurt. Okay, they will hurt. So in those particular portions, what you have to do is those particular patients, you need to get them admitted to the hospital. If they have those full thickness burns in critical areas, again, in the face, the hands, the feet, the genitalia, and there's nobody locally with expertise in taking care of these particular burns, because they will require skin grafts, then you might refer them to the burn center. We have the nearest burn center here is in Gainesville. I happened to, when I was a plastic surgery fellow down in Gainesville a number of years ago, that was one of our responsibilities, to take care of patients there. Burn centers are usually run either by a plastic surgeon or a general surgeon. Fluid loss is a big concern. A big burn has a lot of fluid loss. There's formulas for calculating the size of burns. It's called the rule of 9. You don't need to know that. But you calculate how much the body surface is burned, you calculate their fluid requirements, and you give them half the fluid in the first 8 hours and the other half in the next 16 hours. Problems because of the extensive fluid loss, because now they no longer have a barrier protecting from evaporation and fluid loss. They're losing fluid. Okay, that's why you got to get them dressed up. You got to get them. You got to get medication on them and sterile dressings on them. And you got to get them fluid, because what happens is they'll a lot of times go into renal failure because the kidneys won't be perfused, because the kidneys are not a vital organ. So if they develop hypotension, that's one of the places where it's not perfused. So if you decide to take care of burns as a very specialized thing, you are an admirable person. They get very sick if you take care of them, especially the big burns. You'll be getting consultations from another services, and you'll learn a whole lot of medicine. If you get a chance to rotate on the service, you can learn a whole lot during your clinicals. You can learn a whole lot of stuff by taking care of one of these patients. And that's the end of the lecture. Thank you very much.